Hello everyone and welcome to this video. Today we're going to talk about nephrotic syndrome, not to be confused with nephritic syndrome, which we'll cover in a separate video on this channel. Now this slide shows a cross-section of a capillary within the glomerulus, and the glomerulus is the site where blood gets filtered. Inside the capillary there's blood, and outside the capillary there is something called the Bowman's space. The blood has to move across the glomerular filtration barrier in order to become the filtrate. The filtrate eventually becomes urine. The glomerular filtration barrier is composed of three layers: the endothelial layer, the glomerular basement membrane, and the outermost layer is called the podocyte foot processes. Podocyte refers to this cell that lies outside the capillary. It has these octopus-like arms that wrap around the capillary and end with these tiny processes called the foot processes. And you can see here the endothelial layer has these tiny holes called fenestrae. So it is a fenestrated type of endothelium. The glomerular basement membrane has these small spaces as well, and the podocyte foot processes have something called the slit diaphragms between them. And this slit diaphragm also have very, very small holes. And all of these holes and spaces act as a size barrier to prevent the passage of large molecules. So normally cells such as the red blood cells, white blood cells, normally cannot be filtered into the urine. Albumin, which is very important to our discussion, is actually a small protein. Theoretically, it should be able to pass through these holes and spaces. However, in a healthy kidney, this does not occur. The reason is because albumin is a negatively charged molecule, and the glomerular basement membrane has a negative charge in all of its three layers. So the negative charge of the glomerular basement membrane repels negatively charged molecules such as albumin and prevents them from being filtered. And this is called the charge barrier function of the filtration barrier. Almost all plasma proteins have a negative charge, and that's why the charge barrier function is crucial in preventing the leakage of proteins into the urine. The podocyte has an important role in maintaining the charge barrier because the podocyte secretes a polyanion called podocalcin that is crucial in maintaining the negative charge. Diseases of the podocytes are central to the pathogenesis of nephrotic syndrome. Many causes of the nephrotic syndrome are now thought to be due to abnormalities of or injury to podocytes, and these are called the podocytopathies. Now, podocyte damage can be mediated by cytokines, antibodies, toxins, but regardless of the etiology, damage to the podocytes results in impaired filtration barrier. And this, in turn, leads to leakage of protein into the urine, and this is called proteinuria. Now, what exactly is nephrotic syndrome? Nephrotic syndrome refers to a collection of clinical and laboratory features of kidney disease. The first and most important feature of nephrotic syndrome is heavy proteinuria. And by heavy, we mean more than 3.5 grams of protein lost into the urine within a 24-hour period. This is called nephrotic range proteinuria. The second feature is hypoalbuminemia, which is low serum albumin level. And this makes sense because we're losing albumin into the urine. Third feature is edema, and the other feature is hyperlipidemia. And a useful mnemonic is PALE. The P stands for protein in urine, proteinuria. The A stands for albumin, low serum albumin. The L stands for lipids, hyperlipidemia. And the E stands for edema. Edema is the most common presenting feature of nephrotic syndrome. However, presentation with a complication is also common. Complications include thrombosis, which could be either arterial or venous, most commonly venous, and infections. And these patients are at risk of infections because they're losing immunoglobulins into the urine. Now, thrombosis and infections, these are important features of nephrotic syndrome, but they are not defining features. The defining features are these four. Note that in practice, many clinicians refer to nephrotic range proteinuria as nephrotic syndrome, regardless of whether patients have the other manifestations of the full syndrome, because hypoalbuminemia, edema, and hyperlipidemia are a consequence of the nephrotic range proteinuria. Nephrotic syndrome is characterized by the loss of massive amounts of protein into the urine. The most important of these proteins is albumin, but there are also other proteins lost in the urine, such as antithrombin 3 and immunoglobulins. The loss of immunoglobulins results in an increased risk of infections, and the loss of antithrombin 3, which, as the name implies, it inhibits thrombus formation, and the loss of which results in a hypercoagulable state. Proteins in the blood, mainly albumin, exert a type of osmotic pressure that draws fluid from tissues back into the intravascular compartment. And this type of pressure is called the oncotic pressure. And the loss of albumin in the urine results in hypoalbuminemia, which leads to a decreased oncotic pressure. This causes fluid to leak from the blood back into the interstitial space, and the presence of fluid in the interstitial space is called edema. The hyperproteinemia itself is not usually severe enough to explain the profound edema of the nephrotic syndrome. Therefore, there are two other hypotheses that are developed to explain the edema. The first one is called the underfill hypothesis, and the other one is called the overfill hypothesis. In the underfill hypothesis, which is the classical teaching, the hypoalbuminemia and the reduced oncotic pressure result in leakage of fluid from the intravascular to the interstitial compartment. This leakage of fluid results in a decreased intravascular volume, which results in activation of the renin-angiotensin-aldosterone system, resulting in sodium and water retention. And the sodium and water retention exacerbates the edema. In the overfill hypothesis, it is thought that there is primary sodium retention at the level of the collecting ducts. It is poorly understood why this happens, but it is thought that the delivery of proteins to the collecting ducts results in sodium retention independently of the renin-angiotensin-aldosterone system. And this results in edema. It is thought that this hypothesis, the overfill hypothesis, is the main explanation of the edema in nephrotic syndrome. The liver responds to the reduced oncotic pressure by increasing lipoprotein synthesis, and this results in hypercholesterolemia. We've also outlined the management of nephrotic syndrome. We'll give disease-targeted therapy, which is specific treatment directed against the underlying cause of the nephrotic syndrome. And then we have more general measures that can be taken regardless of the cause. These include drugs that decrease the heavy proteinuria. These drugs are inhibitors of the renin-angiotensin-aldosterone system, so either an angiotensin-converting enzyme inhibitor or an angiotensin receptor blocker. For the hypercoagulable state, we'll give anticoagulants. Now, the prophylactic use of anticoagulants in nephrotic syndrome is controversial, but if the patient is diagnosed with a thrombotic complication such as DVT, pulmonary embolism, or renal vein thrombosis, we'll anticoagulate these patients for the duration of the illness. So, as long as they are nephrotic, they'll be on an anticoagulant. And finally, for the edema, we'll restrict dietary intake of salt to less than 2 grams per day. This is to counteract the sodium retention that occurs in both the underfill and in the overfill hypothesis. We'll also give a diuretic, starting with a loop diuretic, which is a potent type of diuretic, but sometimes we'll add a second diuretic that acts on a different segment of the nephron, such as a thiazide. The causes of nephrotic syndrome can be classified into 3 pathologic patterns according to the findings on kidney biopsy. And these are minimal change disease, membranous nephropathy, and focal segmental glomerulosclerosis. Each of these can be either primary, meaning idiopathic, or secondary to an underlying disease. For example, membranous nephropathy can be either primary or idiopathic, but it also can be secondary to a disease such as systemic lupus erythematosus. Finally, there are two systemic diseases, diabetes mellitus and amyloidosis, that can cause nephrotic syndrome and produce unique findings on kidney biopsy that do not fit into one of these three patterns. The most common cause of nephrotic syndrome in children is minimal change disease, making up 90% of cases of nephrotic syndrome in children under the age of 10. Minimal change disease is also characterized by an excellent response to steroids. And that's why when a child presents with nephrotic syndrome, it is presumed that they have minimal change disease until proven otherwise, and a kidney biopsy is usually not needed for the diagnosis. Kidney biopsy in children is reserved for patients who fail to respond to steroids or those who have some atypical features that makes us think they may have a different diagnosis. In adults, the most common causes are membranous nephropathy and focal segmental glomerulosclerosis. Most adults with nephrotic syndrome require a kidney biopsy. An exception is diabetic glomerulosclerosis, in which the diagnosis is usually fairly obvious without the need of a biopsy. So, to summarize, common exceptions to the need for a renal biopsy in patients with nephrotic syndrome include children, where the diagnosis of minimal change disease can usually be made without a biopsy, and in adults with long-standing history of diabetes mellitus, especially when complicated, and in which case the diagnosis of diabetic glomerulosclerosis may not require a biopsy. The edema occurs initially in loose tissues such as the eyelids, where the tissue hydrostatic pressure is low, as well as in dependent areas such as the feet and ankles, where the intravascular hydrostatic pressure is high. When the edema is generalized and severe, it is called anasarca. Sometimes patients will also have pleural effusions and ascites. Nephrotic patients are at risk of forming thrombi or clots within the blood vessel, and this is mainly due to the loss of antithrombin 3 in urine. Deep venous thrombosis is the most common thrombotic complication, and it may present with lower limb swelling, pain, redness, and hotness, and in which case it should be differentiated from cellulitis, because nephrotic patients are also at risk of infections, including cellulitis. A thrombus may get detached and travels in the blood to reach the pulmonary circulation, and this is known as a pulmonary embolus. A thrombus may also form in the renal vein. When acute, this may present with flank pain and hematuria. If the thrombosis is bilateral, affecting both renal veins, this may lead to an acute kidney injury. More commonly, the thrombus forms gradually. This allows time to form collaterals, and that's why such patients are asymptomatic. Such cases are usually only suspected when the thrombus embolizes to the lungs, so these patients may present with a pulmonary embolus. Another consequence of nephrotic syndrome is the risk of infections, and this is partly due to the loss of immunoglobulin G, or IgG, in urine. Immunoglobulin G has a low molecular weight, and that's why it is more likely to be lost in the urine. Immunoglobulin G has an important function in fighting off encapsulated organisms by opsonization. Therefore, in nephrotic patients, there is an increased risk of infections with encapsulated bacteria, such as Streptococcus pneumoniae. Common infections include respiratory tract infections, urinary tract infections, peritonitis, which is very important to keep in mind, and sepsis. Patients who are persistently nephrotic should be offered pneumococcal vaccinations. Early detection and aggressive treatment of infections rather than antibiotic prophylaxis constitute the best approach. Treatment of nephrotic syndrome includes specific therapy directed against the underlying cause of the nephrotic syndrome. For example, steroids for minimal change disease. And general measures regardless of the cause. For the proteinuria, we'll give a drug with an antiproteinuric effect, such as an ACE inhibitor or an ARB. We'll restrict dietary intake of salt and give a loop diuretic for the edema. We'll give statins for the hyperlipidemia and anticoagulants for the thrombotic risk and vaccination for the pneumococcal disease. And now to summarize, nephrotic syndrome is a collection of clinical and lab features of kidney disease, and we've used the pale mnemonic, proteinuria, albumin, lipids, and edema. Nephrotic range proteinuria is defined as more than 3.5 grams of proteins lost in urine within 24 hours, and this is a number to remember. Edema is the most common presenting feature of nephrotic syndrome, but presentation with a complication is also common. Some patients may present with a thrombus or an infection. The most common cause of nephrotic syndrome in children is minimal change disease. The most common in adults are membranous nephropathy and focal segmental. Renal biopsy is the gold standard test for determining the cause of nephrotic syndrome, and we've talked about a few exceptions. And treatment includes specific therapy directed against the underlying cause and general measures directed against the consequences of the nephrotic syndrome.